Well, hello and welcome to our webinar on one of my favorite subjects, probably not one of some of our patients' favorite subjects, and that is this whole thing of implant disease. This has been a very interesting era, this scenario with placing implants, and then from the standpoint of being able to provide patients with an incredible service that sometimes partials and even sometimes bridges weren't the most appropriate. With this, I thought what I would do with you for our brief time together is to look at both implantitis and mucositis and really go through what I consider to be the premier essential steps. I'm Sam Lau. I am a periodontist at the University of Florida, practiced there for over 3 decades. I have also been very involved in organized dentistry. It was my passion. I'm president of the Florida Dental Association, trustee to the American Dental Association, and I was honored to be the president of the American Academy of Periodontology. Also, I'm a very active member in the Academy of General Dentistry. And when I look at this concept about implants, what has really intrigued us is that we went from sort of thinking that they were incredibly predictable to now finding they're still predictable, but probably not as predictable as we once thought. Now, I do want to preface something. Everyone, you put 2 periodontists in a room, 2 dentists in a room, 2 hygienists in a room, you're going to get 2 different opinions. So as we do this, I try my best to combine both what I consider to be experience, but also science. If there are any periodontists on this, or if you know periodontists, we're anal. We're the ones that want the research. We're the ones that ask, was it a rhesus monkey or a squirrel monkey? That's just who we are. So when we do this, I'm going to do my best to give you some practicality, while at the same time basing it on science. What you see is my email address, slow@dental.ufl.edu. And if you would like a copy of this presentation in color, if you would email me, or if you have questions, I'll be more than happy to respond to your emails. My website is www.drsamlau.com. Yes, I pronounce it Lau. When you're walking through a field and you see something out there with udders, you generally do not call them a cow, you call them a cow. But that is the way that I pronounce it. So let's get started with this. Every speaker should always disclose anytime they get a toothbrush or a piece of floss or money or whatever. So these are my disclosures. I am part of Florida Probe Incorporated. I helped start it. We call that VoiceWorks. I am part of the Perio Sciences. You'll see a little bit of this when we talk. It is an antioxidant gel. I'm part of BioLace. I am actually their chief dental officer. Philips Sonicare, I love their products, but I also love Procter & Gamble. I love Oral-B. EMS, I will speak to that. This is your airflow with glycine and glycerol. Probiora, sort of a new kid on the block. These are your oral probiotics. So therefore, when we by the way, I taught high school biology before I went to dental school. My parents were teachers. I wanted to go, and I did go into private practice, but still academics was still primarily my forte. But we academicians truly believe that we should establish what you're supposed to get out of this and reinforce it. And we call that learning objectives. I call it, what are you going to take home? I'm one that believes that if I'm going to spend some time on a webinar, then I need something for Monday morning. And that is my plan. Our objectives are 4. let's find ways to where we can actually be able to find implantitis and mucositis and differentiate between the two. Let's create ways to where our patients can actually maintain these implants. That's not going to be easy for some. Let's make sure that you and I can determine what we're going to do at the chair, both for mucositis and for implantitis. 98% of probably all implant mucositis is managed by a dental hygienist. It's the same thing is true for perio. But for those of you who would like to go one step further and deal with the implantitis, then we're going to cover that too within our brief time together. But probably the most important when it comes to implantitis is that we're going to actually move into the area of what is this about the implant surface and decontamination. I will reinforce with you, some of this is controversial, but I do want to give you some, what I consider to be some fairly time-honored techniques on how we deal with this. Implants are not new. The Egyptians back in the day were using shells and ivory to replace missing teeth. 2000 BC. You see the ancient Mayans out there, Romans with fixed prosthesis. But then there was manna from heaven in the form of someone called Dr. Brennemark. And Dr. Brennemark was an orthopedic surgeon who took titanium metal and realized that you could fuse bone to titanium. From there, it took no prisoners. We began to create titanium roots implanted in patients. We began to look at different kinds of surfaces for implants. We had long implants, short implants, big implants, small implants, plasma spray implants, anodized implants, but they began to work. And in the late 90s, this thing called All-on-4, All-on-6 was introduced, which most of you are very aware of. And as we moved forward, we began to continue to look at surfaces, cross platforms, different kinds of restorations. All of that created something called a major business with the endosseous root-formed implant. Although it's difficult to determine, we believe that there's probably about 2.7 million implants placed per year. Huge industry in the United States, and even more so in some of the European countries, where implants may be less expensive than they are in the United States. So if we place a lot of implants, we might ask ourselves, what's the failure rate of implants? Well, let's face it, we don't ever want to talk about failure rate of anything that we do, because that would have meant that we're a failure. But all of you would not be attending this. And I think there's like 1,200 plus 1,300 people attending this right now, if you weren't concerned about how do we manage implants. Industry continues to focus on stabilization, supporting structures, and absolutely on aesthetics. Implants are here, they're not going anywhere. Let's you and I take a look at the difference between a tooth and an implant, because that begins the crux of our whole time together. If you compare the two, and you look at from the standpoint of a tooth, and you begin to go from coronal apical, you go through some structures. If you're pretty heavy-handed with your periodontal probe, you'll end up on the bone at 50-gram force. So you start with your sulcus, your junctional epithelium, your supracrestal fibers, your cementum, your PDL, and bone. We love the PDL because it's kind of like a trampoline. So our occlusal forces, for the most part, the body can handle. with the exception of when we really get into some extraneous, lateral forces or clenching. Now let's go over to the implant. Well, it has a sulcus, it has junctional epithelium, but that's where it ends. The supracrustal fibers are not engaged into bone. They're actually like what we call an adherence. And then there's no periodontal ligament. We have something called BIC, bone implant contact. That means that the bone is osteointegrated, yes, an incredible word that became with Dr. Brandmark. And then we have no cementum, but then we pick it back up where we have bone. So one makes a conversation as to what will survive better, a tooth or an implant. And for the most part, the vote is still on the teeth because they have, first of all, trampolines, and secondly, they have attached fibers. But if you don't have teeth, an implant is a very welcoming entity for what we do. The relationship of soft tissue to implants, again, is based on the amount of force of your periodontal probe. While the junctional epithelium is there are no Sharpie's fibers. The attachment is hemidesmosomal. The connective tissue is more circumferential and perpendicular. And then when we take a look at that component called bone, one can see that at the 3, 9, 12, 18 months, we go through from healing to remodeling through this whole dynamic equilibrium as we achieve this bone implant contact. Now, this is where it gets a little controversial because I, for one, still believe occlusion is a factor in the life of an implant because bone is dynamic. But you read one article that says, forget it. You read another article that says it's important. But it's not just because I'm a faculty member at Pankey Institute. For us, as oral healthcare professionals, occlusion is still a very, very important process, whether it be natural teeth or whether it be implants. When one looks at an implant restored, sometimes even I forget that it is an engineering marvel. It may be small, but there is many, many things in there that create the implant to the abutment to the restoration. And with it is threads and screws, etc. So let's begin. How do we lose an implant? Well, we could have a fractured or loosened some of these screws. We could have fixture loss. You probably have experienced that. We could have poor oral hygiene. You see that all the time. Soft tissue reactions, especially with minimal attached gingiva. Broken attachments, absolutely. And even broken fractured implants. So any one of these is an Achilles heel. And therefore, we do see this. We forget that there's probably 300-pound force in the jaws with the masseters. Incredible force. And much of that can be 24 hours a day. And none of us like to see this, especially the patients. But it does occur. Every now and then we see an implant where the screws loose. And when they loosen, it becomes a great harbor, percolation for microbial insult. Now, we do know that most of the organisms that we see in periodontitis are the same that we see in mucositis and implantitis. But that still means they're still there. And we become, again, engineers as we begin to replace abutments and deal with all of the prosthetic issues. And let me stop for just a moment. Many of the implant complications are as much due to prosthetics as it are the bone implant contact. It's time to somewhat put the old adage that everything is about cement sort of behind us, because most implants today are screw retained, although some of the earlier implants still have cement. And when you do cement, I'll be the first to tell you, it is an incredible foreign body. When you see biopsies of implantitis and you see small particles of cement in there, you also see you see your giant cells, macrophages, because it is a foreign body reaction. We'll talk more about foreign body reactions here in a moment. This was sent to me from a BioLace laser user. He was using an I+. Don't know if this was his implant or not, but up in the upper left, you see the cement extruding. And so he said, what the heck, I'll just use my laser to remove the cement. And it can, because erbium lasers will look for water in resin. By the way, I'm not sure if you're aware, but you can remove veneers, zirconium crowns with erbium lasers, and probably with veneers, probably about 30 seconds per veneer. The crown takes a little longer, maybe about 2.5 to 3 minutes, and they just literally pop off because they're looking for the water in the resin. But when you see this, I can promise you, you're going to see inflammation. Because whether it harbors the microbial flora or whether this is just a foreign body experience, the body is saying, I see the stimulus and I've got to deal with that stimulus. And again, with loosening of screws, they become a harbor for microbial flora, again, through something like percolation. And notice just the amount of osseous resorption that one sees in our radiograph over on the right. It is, again, like the body is saying, I don't want you anymore. No one wants a fractured abutment screw at 5 o'clock on your last day of the week of practice. This can make you psychotic, neurotic first, and then psychotic. You see it, but you just can't get it to move counterclockwise. And yes, remember, you do need it to go counterclockwise. Everybody's got an idea. One of the most popular is to take a very sharp explorer and take the edge of the screw and attempt to gently turn it in a counterclockwise so that it can unscrew. And you have to be very careful because you don't want to damage the threads as you do that. Every now and then, you've got to literally drill the screw out. And then we end up with what we call name that implant, because there are hundreds of implant companies out there, and they create all different kinds of implants. And whether you're rest of world or domestic, we're a very transient society. I'm always getting on blogs, what is this implant? Help me, because I can't find the pieces. We hear this constantly, and you're going to hear about it even more. So even with these things of full coverage, a lost clip, all of this, remember, the mouth is an incredibly active organ, and what can happen will happen. This just occurred. I wanted to show you this piece of research that was in Clinical Oral Implants Research 2021. And I think it's like periodontitis, the silent disease. Peri-implant pathology is usually asymptomatic and leads to silent disease. Cross-sectional observation study of symptoms and perceptions reported by patients with implant disease. The bottom line is the prevalence of peri-implantitis, unfortunately, was 57% in this group on a patient level. 28% of all the individual implants had implantitis at a 7 to 8 year loading period, 90% of implants that were sick were perceived as healthy by the patients, even though these implants were known to be clinically diagnosed with implantitis. The bottom line is that peri-implant diseases are not perceived by most patients. And when the patients have very severe symptoms and try to pursue dental treatment, it may be too late. And I'm going to talk to you about it being too late with implant diseases. Again, no patient wants you to say, we have to take the implant out. Those are fighting words. In 2017, 2018, the European Federation of Perio, along with the American Academy of Perio, decided that it was time for a new classification since we'd not had one since 1999. However, this classification would now include not just perio, but for the first time, implants. With that classification, they divided implant diseases into 4 categories: perfection, peri-implant health, nothing going on, no bleeding, suppuration. 2, peri-implant mucositis, in which you have inflammation but no bone loss. Peri-implantitis, in which you have inflammation, but also now progressive loss of bone. And for the first time, they created something that all of us knew: the fact that you can have deficiencies around implants, but it may not be to microbial flora. It could be the fact that it was placed incorrectly. It may be the fact of extraction trauma. And so therefore, we want to deal with these 4 areas as I described for you how I would manage each one of these. There are 2 major implant-related diseases. One is mucositis, one is implantitis. Let's talk about mucositis first. Naturally, there are no signs of bone loss. I just finished doing a 4-hour virtual hands-on on how to manage implantitis and periodontitis with lasers. Someone asked me, well, what's the probing depth that I need to be concerned about? And my response was, forget about the probing depth. Look at the radiographs and look at bleeding or suppuration. The beauty of implant mucositis is that it is definitely reversible. When one sees these implants, it's very clear that something is going on. Don't know if you can see my arrow, but I'm going to use it anyway. Something is going on these 2 distal abutments, especially over on the one on the right. It could be anything. It could be a loose or fractured abutment, but you're going to need to take a radiograph to determine really what the etiology is for this. Oral hygiene is always going to be critical to us. And as we begin to build these prostheses, sometimes it's difficult for us to continue to think about how the patient's going to clean it. And notice the amount of calculus, but you're not surprised. This is what we would call salivary calculus. This is actually coming out of the ducts, sublingual ducts, and you would see this primarily on a mandibular prosthesis. But yes, you and I go back to the American Academy of Perio, European Federation of Perio, and this is what they said were the primary risk factors for mucositis. They told us that definitively it is biofilm, smoking, and radiation. Those are the 3 primary risk factors for mucositis. Now, possible risk factors would be diabetes, in other words, indirect relationships, the lack of keratinization, that's one of my favorites, and we revisit the thing about the cement. Looking at that, our diagnostic criteria For determining if a patient has implant mucositis, first of all, you would think of using a periodontal probe. And yes, you would. And if you want to record the numbers, be my guest, but they're probably going to be fraught with error. You're going to end up with 10, 4, 15. Because sometimes you're not even you're possibly probing all the way to the bone. Secondly, you have such a huge convexity on some of these crowns, it's like a mushroom on a stalk, that is hard to measure. So I tell the team and myself, don't rely on probing numbers. Look for bleeding and suppuration, and especially look at the radiographs. Where is the relationship? And the radiographs have to be good, by the way. It's taken straight on, not with all these angulations. Actually, if you had your way, it would be the vertical bite wing. What you do is you take the relationship of the bone and you take a look at it to the abutment and to where your very first thread is. And don't be mesmerized if you see angular bone loss, but the angular bone loss goes to the machined part. That's only natural. That's because the implant was submerged. That doesn't mean that was bone loss. And one evaluates the occlusion and the prosthetic stability. I personally like plastic probes because they bend. It's not because I think I'm going to tear up the titanium, but I like them because they bend, and you need them to bend around the convexity of some of these restorations. In probing, therefore, the thinner the probe, by far, the more accurate is going to be the probing. Your probe should be 4 to 5/10 of a millimeter in diameter. We always say, if you want to create periodontal disease, use a thin probe. If you manage the periodontal disease and you want to make sure that you did very well, come back and measure it with a thick probe. I'm kidding. But one tries to probe along the long axis. So by far, the best way to probe an implant is to take the prosthesis off of it. That's not easily done, especially if it's cemented. But try your best to probe along the long axis if you want predictability. When we look at accessibility, it really comes down to what? A patient's management of their mouth after they leave you. For you to gain accessibility as a oral health care professional, you may need to adjust the prosthesis. You may need to remove some of the acrylic on the lip of the prosthesis. But it's all about oral hygiene and biofilm removal. If you can remove the prosthesis, it's very much easier to measure, to determine what's under there. But all of you know that these are either screw retained or cement retained. And we're going to get into a debate here in a moment of how often you should take the prosthesis off so that you can debride it professionally. These are not easy. If anything, I'm going to be realistic and candid with you. You cannot probe this. You can barely, you as a professional, can barely debride this. And don't think for a minute that a patient is going to be immaculate in their oral hygiene. But I'd rather look in the eye of the tiger than think everything is fine. When we talk about implants, my point to you about angular goes over to this most distal implant. You'll see that the implant is slightly angled, but you'll notice that this little angular area here is starting to get involved in a thread, but it is not near the osseous resorption that you would think, because bone cannot attach to a machine surface that I'm aware of. You don't get bone implant contact to a machined surface. You get a connective tissue adherence to a machine surface. So in my mind, theoretically, this is still implant mucositis. And what about attached gingiva? We always believe add the attached gingiva before you place the implant. I mean, you could put a 5-pound piece of gum on here, but implants do not have blood vessels in them. So therefore, you're not going to grow gingiva over a thread. Now, you may bulk it out, and we do that for aesthetics, but don't think for a minute it's going to attach to a piece of titanium that has no blood vessels in it. Not only do we not like this, this is where patients will tell you there's an issue. They'll say, every time I touch that area, it hurts. Why? Because there's no keratinization there. The alveolar mucosa is very fragile, and it's going to bleed. As you look at this, I want to suggest something to you. If you look over on the distal implant, do you notice how you can almost see the threads through the tissue here? And so there is definitely a dehiscence going on. Let's go back to the chair. And what are we going to tell our patients? Well, we've got flossing, we've got interdental systems, we've got specialty atoms, we got everything for this. I mean, you name it, there's an oral hygiene device for every patient, a different one for every patient. Flossing. We've got the super floss. We got thin floss, we got big floss, we got floss threaders. And most of the time, patients cannot negotiate this. It's great for me to use this to photograph it so you can see how they're working. But patients, you got to have the patient doing this every day. Only 7% of perio patients do this every day. By the way, that's the data. Patients of record, only 7% of patients floss every single day. Now, let's add something to this. If you think a patient's going to thread this through there, maybe if they're a seamstress, but this is just not going to happen. Let's find user-friendly things for them. They are not going to do this. And if they probably did it, they probably caused trauma. And we do know that dental floss is a possible risk factor for the development of peri-implant disease, an observational study of 10 cases. In vitro tested yielded that the application of various types of dental floss on exposed rough implant surfaces may easily lead to the tearing of the floss. The floss may end up in the tissue itself and possibly could even create a little bit of inflammation. So therefore, let's face it, flossing is going down. If you look at the dollars, there's being less and less floss, probably a little bit more of the flossers because of convenience, but what is coming up? To a certain degree, dental picks, and for the most part, my most favorite, interdental brushes. And so I'm going to be, a little, you did not see this on my disclosure because, I may get some toothbrushes from Sunstar. But this is manna from heaven, my friends. When somebody came out with these kinds of things that are like soft picks, that changed everything. Because now patients can use these 75 little tiny rubber bristles. When these things first came out, believe me, they were back ordered. Everyone, where are they? Where are they? We need them. We got to have them. And the studies then begin to also demonstrate that they were as effective as floss. I love these things, whether it be for wider spaces, for original. And the fact is, the studies do demonstrate that they are able to disrupt the biofilm. They are able to reduce gingivitis. And then manufacturers begin to make them differently. They make them big, they make them small, they make them easy. Patients love things like the advanced, to where they can get their fingers around it, hold it, especially for implant patients. These, no matter what manufacturer, they gently remove, they dislodge food, they massage gums, but I'm into biofilm. They have improved grip for control, easy to manage in the mouth. And so now they even come up with mint flavored ones now, Comfort Flex. So that it's all about what? Maneuverability, access for the patient. And when you have spaces, we periodontists have been using interdental brushes probably since the Egyptian days, if there were periodontists around. This is our namesake. And when you look at interdental brushes versus dental floss, every study shows that the interdental brush is more effective. 39.6% versus 58.3% compared with using dental floss. Interdental brushes are more effective at controlling interproximal dental bio around teeth. So I strongly ask you to go to interdental brushes or soft picks. My favorite are going to be interdental brushes for implants. They are your mainstay. Be looking for the ones that where they create certain things that are creative on how to do that, whether it be handles. These things work. I hope you see that this is so much more effective than trying to put floss around these particular areas. And whether it be in-tuft brushes, you name it, they work. Electric. I highly recommend that you also, in addition to manual, consider electric toothbrushes. One of my favorites is this air floss. And you can put pure medicament in here and shoot it under those prostheses, especially all on 4, all on 6, to disrupt the biofilm. We place something called Periosciences rinse in there. Or we use the Periosciences gel, but there's other things out there. The essential oils, many products that are out there. We primarily, for us, we use Periosciences for these kinds of arenas, and this is Periosciences. We also have our patients on these something called Probiora for the standpoint from the oral probiotics. But this is the bottom line. You and I now talk about the chair for hygienists. Non-surgical studies do demonstrate that many things are effective, but not these. These do not work. Please bury them. You know they don't work. So what are we going to do? Well, we can't use ultrasonics because we'll rip the implant up. So we try to use things on top of the ultrasonics, but many times they're large. We also know that we have to be careful scraping on these implants because they'll create foreign bodies. Therefore, most of us are going towards air medicinal delivery. And there are many manufacturers out there for this. Whether it be Acteon or EMS, this is what we're using. We're taking things like this and making it look like this. Yes, things that are this, making it look like this in 45 seconds. And we're doing that by using glycine. My favorite is erythritol, plant-based powder for these implants. That is what we are using. And it becomes our number one in managing implant mucositis are these erythritol medicinal airflow devices. So in class 1, where we have no exposure of the implant surface, we're using air polishing. Where we have class 2, where we have some titanium, we're using air polishing. We have to be very careful using diodes so that it will not heat up the implant. We're using ultrasonics for supragingival. And when the implant is really exposed, then we may possibly not have to only use air polishing, but now we're going to have to consider surgical as we move into implantitis. Now that was mucositis. We talked about what to do at the chair. We talked about how to find it. We talked about what to do at home. Implantitis is different. This is where the threads have no bone on them. We now know with studies that we're approaching almost 20%, 1 out of every 5 implants are lost over time. And the number one risk factor is a history of severe peritonitis, is how they lost those teeth. So if I work that 2.7 million implants, this is by Dr. Fromm, if I lose 10% of them, I'm going to lose 270,000 a year. Over 5 years, I'd use 1.4 million implants. And that's the problem. This is what it costs to place an implant restored in New York City. $6,420. I'm indebted to Scott Fromm for creating this. This is what it costs if I have to remove the implant, place another one. $8,720. You know what the trick is? Don't lose them. So if you and I look at implant failure, and we look at the prevalence and risk of factors, what we look at is smoking is a pretty big deal. What we look at is having peritonitis prior is a big deal. Oral hygiene is a big deal. And you know what the number one protective is to prevent it? Interproximal brushing. So let's go back to implantitis and look at the AAP classification. The primary is a history of chronic peritonitis, poor plaque skills, no regular maintenance. The possible is smoking, diabetes, all the way down to the positioning of the implants. And don't forget about occlusion. No, these are not photoshopped. And yes, you can probably pick up a good FM station. And if you put a lot in, if something goes wrong, you still have a lot left. And you can be very creative on abutments. Placement issues become extremely important here. You're probably asking yourself, what were they thinking? I'm not sure. So the risk factors for peri-implantitis are significant. But what we have is much larger osseous defects with implants than we see with periodontal disease. And some of that's dependent upon the kind of surfaces that we have. And now what we know is that implant disease may also be due to corrosion of the implants, because people like Tom Wilson have found in biopsies titanium oxide particulates. And we're starting to see more and more discussion over dissolved titanium with these titanium oxide particulates. It may be a reason why some folks are going towards zirconium implants. So how are we going to manage this? Are we going to use regenerative surgery? How are we going to decontaminate the implants? Well, Dr. Fromm, along with Paul Rosen, have developed some techniques for implantitis, including definitely flap. But let's face it, this is 13 steps. From amoxicillin to imdegene, to bios, puros, to Ossix membranes. And when we look at implantitis, yes, this is somewhat predictable. Of detoxifying the implant surface, this is using tetracycline. Of using osseous materials. But now we're going to get into that issue of how do I detoxify an implant surface so that the bone will want to osteointegrate in it? First of all, I better find out how I got the implantitis in the first place. So we got hydrochloric acid, we got tetracycline, we got EDTA, we got hydrogen peroxide, we got erbium, we got, you name it, we have got it. We have got all kinds of grafting material, from freeze-dried bone to biologics to membranes. We have people even grinding off the threads, which, by the way, is not so much in concert as it was before, because for the most part, when you grind off the threads, you throw all the titanium oxide into the soft tissue, and my goodness, you are going to have a foreign body reaction. And then someone even came up with implant brushes to try to detoxify. I was with a periodontist not too long ago. I said, you know about these implant brushes? He says, Sam, I got a drawer full of them. Would you like to buy them? So let's finish up and talk about lasers. If you want to use a diode laser for laser bacteria reduction, please use it with an uninitiated tip on a very, like 0.5, but don't touch that implant or it will hurt it. You can't do this with a diode laser. It will fry the implant. So one has to be very, very careful with Nd:YAG and diodes. Because if you're not careful, these are actual implants that have literally cracked or melted from using diode laser, but not erbium. Erbium laser does not have an adverse thermal effect on implant surfaces. And as you can see here on the left, no erbium laser. Over on the right, you see bone growing into the threads of the implant. So what is this laser doing to the surface? Well, it's very possible that it could be detoxifying, removing bacteria, removing any type of naturally biofilm or endotoxins, but it also may be removing titanium oxide. And I'm indebted, this is International Journal of Peri-Restorative Dentistry by Mark and Ron Nevins and Dr. Yamamoto, demonstrating that if you do use an erbium laser, you can literally remove the titanium oxide and get it back to where it was, so that now you have the ability to have a new bone implant contact. And studies, including in the Journal of Periodontology, demonstrate that not only can you do 95% removal of the biofilm, but you can affect the surface and not create an adverse surface and get a new system. One of these erbiums is a BioLace laser. It is an erbium chromium YSGG laser. These erbium lasers use photoacoustic streaming with bubbles, and look at the results. Now, it's not perfect. If you look at the upper right, looking at the pre-op on the upper left, same thing on the bottom, look at the lower left as pre-op. It's not perfect, but you know what it did? It stopped it. And now we have studies that demonstrate that we can reduce pockets, that we can grow bone. And in a great study by Don Klim and Jack Gonsoley, peri-implantitis treatment using erbium YAG laser for bone grafting. We use either erbium YAG, my favorite is erbium chromium, there are reasons for that, but growing bone. And then in November of 2020, a fairly landmark study, human histology, again with Mark Nevins, David Kim, others, took implants that anyone would have taken out, and using tips that are designed to detoxify the surface, again using erbium chromium YSGG, this happened to be a BioLace, water-lace laser. Notice how the bone grew back. And if you look at the histology, you'll notice that the bone grew back into the threads that had literally been exposed to biofilm, demonstrating that now lasers may be one of the first lines of defense in managing implantitis. Great before and after by Todd Jorgensen, periodontist in Scottsdale, showing how we can now reverse these implants. Here, he used a little bit of grafting material, but these are 1 or 2 year post-ops. So now you see the kinds of tips that we are using to make this happen. And this just happens to be what's called a side-firing tip. By the way, if you look at the bottom left, this is very permanent implant cement. This was a study done by Chris Walensky. He's presently at Touro University. And notice how he used this laser energy. It's kind of like a periscope. that literally went into the threads and removed that cement and had no negative effect whatsoever on the implant surface. So you need something that's going to direct the energy direct into the threads. You know, I was thinking the other day, why do we have so much implantitis? And then it dawned on me, what is implantitis? I mean, it's like Fergus on steroids. How difficult is it to clean it? So we do decortication, and we do these kinds of procedures that you see, you know, in this video, where we degranulate and we detoxify the implant surface. And here is that side-firing tip going into the implant itself. And notice how it's shooting the energy directly into the threads to detoxify it and make it more receptive, especially if you're going to use bone grafting material, to reverse that. So Sam is going to leave you with implantitis. You got to degranulate, you got to detoxify, or you got to decorticate. Our friends, this is just not going to happen. And you've got to do it meticulously. What I'm going to suggest to you is not to get on a podium and preach to you, but I'm going to leave you with a couple of thoughts. If you're going to manage implantitis at the chair, please try to remove the prosthesis before you start, if at all possible. Or you're never going to get down to those threads. No more than a hygienist is going to get down to them, get down even to the machine part with mucositis. We recommend that you can do sort of a mini flap if you have just one or two threads exposed. But if you have more than one or two threads exposed, you've got to do an open flap. Quit messing around with these little conservative procedures. You got to do an open flap. I highly recommend it has to be a laser. You have to detoxify the implant. I'm very open to augmentation or biologics if you have walls, like a 2-wall, 3-wall defect. And you might even consider guided implant regeneration with that. And by the way, for those of you in the United States, please look at your ADA CDD codes, because they're codes for this. They're codes for debridement of implant surfaces, including adding osseous with that. So I'm going to leave you with some points. 1, please, my friends, when you see mucositis, attack it. Do not watch and wait. Please, my friends, when you see any bone loss apical to that machine, I want you to treat it, whether it be mini flap or flap. I do not want you to watch and wait. Every study shows that bone loss in implantitis is absolutely exponential, where bone loss with periodontitis is more linear. You cannot take a chance. What you use on a tooth cannot always be used on an implant. I'm talking diodes. Present evidence suggests that the use of laser to manage implantitis is there. When a patient loses a tooth, you know, and you've kept it for 20 years for them, you know what my patient would say? Thank you. Thank you, Dr. Lau. When a patient loses an implant, again, they're ready to attack you. Let's not lose any more implants. Let's place them well, and when we see implant disease, let's reverse it. Again, if you would like a copy of this, or I can help you with any questions that you may have, slow@dental.ufl.edu. My website is drsamlau.com. And now I will turn this back over to Viva Learning. And we will look at a few questions. Any thoughts on mixing splinting implants with teeth in multiple units? I have seen this question before. And, you know, there's mixed thoughts about it.
Alert from your disc is
So
almost full.
when you look at this,
Alert from calendar.
so personally,
the essential steps to manage implant disease from operatory to patient.
My computer's talking to me. But when you look at this, you know, one is ankylosed and one is, for the most part, has the trampoline, how we talked at the very beginning. So, you know, I'm not totally sure I would want to do that unless I had some type of post and core, some, some kind of flexibility with like an implant supported abutment, implant supported cone with a natural tooth. My first thought would be, don't do it. I like implants separated from natural teeth. What do you think about water flosser, hydrofloss, water pick? Absolutely, but Sam believes in this. One needs to consider when you're looking at this of what I call M&M, and this is also true for natural teeth. M&M, mechanical and medicinal. What that means is you need to remove the mechanically the biofilm and then come back with medicinal. If you have nothing else better than this, please do your best. But I believe in mechanical interdental brushes or soft picks, followed by some type of medicinal delivery. My favorite is air floss, although I'm very much okay with other types of water flossers. Can you use implant on tooth for doing a bridge? Can you use implant on tooth? That's back to the question that we talked about before. Are there any studies protocol actually to remove implant restoration, irrigate at the 1, 2, 3 years interval in order to prevent peri-implantitis? Yes, there are some about removing the implant restoration. Actually, there are some studies where you remove the overstructure and literally do what we suggested with implant repair and then bury the implant and wake it up again. So one does see that out there too. So there are some scenarios whereby we take a look at this whole mucositis implantitis thing, but just let me give you again, please stop using curettes on implants. Please stop watching and waiting on implantitis. I do believe that my concern is that there'll start to be a negative backlash about patients with implants. There already is somewhat, patients are now sort of wanting to keep their teeth. That's probably endodontists are doing so well. But for the most part, implants are here and implants are here to stay. So again, thank you very much. If I can help you in the future, let me know. Thank you very much for being here and being able to share with you about this whole thing of implant disease. Thank you.